This recorded lecture will be going over Chapter 31, the musculoskeletal system, in the MedSurg textbook. The musculoskeletal system consists of the bones, joints, cartilage, ligaments, tendons, and muscles. There are three types of bone cells. Osteoblasts are responsible for bone growth by making new bone cells and secreting collagen. Osteocytes regulate mineral uptake and release. Osteoclasts dissolve minerals for release into the bloodstream. Ligaments join the bones of a joint together. Tendons are connective tissues that provide joint movement. Cartilage is a type of connective tissue in which fibers and cells are embedded in a semi-solid gel material. A bursa is a fluid-filled sac that provides cushioning at friction points in a freely movable joint. Functions of bones. The red bone marrow in the spongy bones forms red blood cells, white blood cells, and platelets. Bone is maintained by remodeling. Existing bone is reabsorbed into the body, and new bone is built by osteoblasts to replace it. Contraction of skeletal muscles is produced by synchronized contraction of many muscle fibers. Skeletal muscles will contract. This provides movement, joint stability, maintenance of posture, and produces body heat. Aging-related changes in the body. Ossification is the replacement of cartilage by solid bony tissue. This is not completed by the body until about age 20 to 25. The loss of bone mass or osteoporosis will occur with aging, and it is more severe in women. Crepitation is a grating sound in the joints. This can result from joint cartilage thinning and eroding after years of use. It will result in stiffness of the joints. Joint motion can decrease, limiting mobility and leading to swelling. Muscle cramping, especially at night, will increase due to impaired circulation and accumulation of metabolic wastes. We can see this picture of the major bones of the human skeleton on page 744. And we can see this picture of a long bone on page 745. And a lot of this should be a review for you from our structure and function content in Foundations 1. Disease, trauma, malnutrition, and aging all contribute to musculoskeletal problems. Trauma can cause bruising, strain, sprain, or fracture. Poor nutrition can deprive the body of sufficient calcium and phosphorus that we need to build strong bones. Tumors can invade the bone either as a primary or a metastatic cancer. Prevention of motion and mobility are important to prevent long-term orthopedic disability. Weight-bearing exercise throughout life is needed to maintain bone mass, and this can decrease the incidence of osteoporosis, increase muscle strength, mass, agility, balance, and coordination, therefore preventing falls and consequent fractures. Lifting and moving objects correctly using large muscle groups will help prevent muscle strain and sprain. Seatbelt use in an automobile will reduce the incidence of trauma to bone and muscle that could happen during an accident. Wearing bicycle, motorcycle, or other sports helmets will reduce the incidence of skull fractures. Refraining from using steroids on a long-term basis will also help prevent osteoporosis and fractures. Laboratory blood tests are performed on the minerals needed for bone growth. This would be calcium and phosphorus, in order to detect bone disorders, including bone metastasis, muscle damage, gout, or diagnose rheumatoid arthritis or another connective tissue disease. Range of motion testing will involve both active and passive maneuvers. In active testing, the part being measured must be moved by the patient. In passive testing, the evaluator will move the body part while the patient is relaxed. The measurement of range of motion in a joint is called goniometry. You can see a similar picture to this on page 746. One system of measurement commonly used is based on a full circle of 360 degrees. Each joint is evaluated in terms of the number of degrees that it can be moved from the zero position. Muscle strength can be measured based on the ability of a muscle to move the part of what it is attached to, working against the force of gravity. We use a grading system for this, ranging from grade 5, which is normal strength, to grade 0, which is complete paralysis. When reviewing a patient's past history, keep in mind the significance of disorders that will primarily affect other systems, but secondarily affect bones and muscles. Family history can be significant because some bone and muscle disorders are inherited or have a familial tendency. Observe your patient for signs of joint pain, such as limping, poor posture, awkward gait, difficulty in arising or walking, and wincing upon movement. Watch the patient during performance of ADLs and note any problems of movement, including changes in facial expression, to pick up any signs of problems. Sometimes it will be necessary to consult family members or someone who lives with the patient to find out information about their true ability to perform ADLs. A self-care deficit is one of the primary issues for patients who have problems with mobility. Making beds for bed-confined orthopedic patients is best completed by 2 people. Planning for toileting needs at regular intervals is important for the well-being of a patient who is unable to get out of bed without assistance. Repositioning the patient at 2-hour intervals should be included in the daily work plan to prevent pressure ulcers. Constipation, altered tissue integrity, social isolation, potential for injury, and other problems caused by immobility could occur. The physical therapist and occupational therapist are especially important and will act as a resource for you and your patient. Patients with musculoskeletal problems need to change their body position frequently and get up in a chair to prevent pressure ulcers, circulatory stasis, and any respiratory or urinary complications. It is also necessary to change joint positions to prevent joint deformity. Observe the patient during routine range of motion exercises. If any tightness or resistance to joint motion is noticed, you should position the joint extended so that the muscles are stretched to normal limit to prevent the development of contractures. Patients with flaccid paralysis are not necessarily positioned in the same way as those with spastic paralysis. Patients with flaccid paralysis should have their joint position changed frequently. Use a bed cradle or pillows positioned at the foot of the bed to relieve pressure of the bedclothes to help prevent foot drop in patients. Ankylosis is the result of injury or disease in which the tissues of the joint are replaced by a bony overgrowth. This can completely obliterate the joint. Proper positioning and movement of the joint passively can help prevent this. When working with orthopedic patients, all movements should be gentle and firm. When moving or turning the patient, be sure to obtain sufficient help from adequately trained personnel. If the patient can help without damaging their diseased joint or limb, encourage them to do so. If they are unable to help, explain the procedure and instruct them to completely relax. Many times the patient will be afraid that moving and turning will cause them pain. Explaining long-term benefits, such as preserving skin integrity and decreasing respiratory problems, can increase a patient's cooperation. Range of motion exercises, both passive and active, are planned and carried out as soon as feasible after decreased mobility occurs as a result of disease, injury, or surgery. Range of motion exercises should be completed 3 to 4 times per day. Isometric exercises involve generating tension between 2 opposing sets of muscles. For example, trying to flex the lower arm while using the opposite hand to try to extend it. See the safety alert on page 753 in the red box. Caution with isometric exercises. Isometric exercise can be contraindicated in patients with hypertension, increased intracranial pressure, or congestive heart failure, because isometric exercises will cause a significant increase in blood pressure and heart rate. Progressive mobilization involves assessing the patient's ability to move their limbs, turn in bed, transfer from bed to chair and back again, and stand and walk. These are measurable signs of independent movement and will represent various stages to which the patient can gradually progress. Setting goals for progressive mobilization should consider the pathologic condition causing the immobility, any contraindications to movement of a body part, and the ability of the patient to understand and take part in carrying out rehabilitation activities. If the patient is to be cared for by family members once they are back at home, it is essential that those family members be included in planning and setting goals of intervention to prevent disability and promote mobilization. Patients suffering from intense joint pain as a result of rheumatoid arthritis would need proper timing of exercises to follow the administration of analgesic and anti-inflammatory drugs. If possible, the schedule for drug administration should be adjusted so that the patient will receive their first dose of medication in the morning, about 30 to 60 minutes before they start their exercises. Sometimes after a total knee replacement, the surgeon will order attachment of an apparatus to the affected limb that provides continuous passive motion of the joint within set limits. This apparatus is driven by a motor and requires no effort on the part of the patient or the part of the nurse to move the limb. It is used intermittently throughout the day. When this type of apparatus is used, the nursing care plan should include specific instructions regarding its proper application and setting and regular assessment of adequacy of pain relief. Pain is helped by the continuous circulation of ice water through a pad placed on the knee or affected joint. The cold helps reduce swelling, inflammation, and pain. For convalescent patients or those who may need support while walking, crutches could mean the difference between freedom to move about and confinement to one location or a wheelchair. Before attempting to walk with crutches, the patient should be instructed in their use and manipulation to ambulate safely and effectively. If crutches are too short or too long, patients will have problems with moving and shifting their weight. When walking, the patient should straighten their elbow and the wrist during weight bearing. Although the physical therapist will supervise the preparation and instruction of patients before they start to use crutches and then evaluate their ability to use them correctly, you will still sometimes be responsible for assisting the patient with crutch walking while they're in the hospital. When teaching a patient to ambulate with a cane, be certain that the cane has an intact rubber tip. The cane is the right length if the hand grip is at hip level and the elbow is bent at a 30-degree angle when weight is placed on the cane. This should be used on the good side unless the healthcare provider orders otherwise. The patient should look straight ahead rather than down when they ambulate. The cane should be advanced at the same time as the affected leg. Walker height will be correct when the person's elbow is bent at a 15 to 30-degree angle while standing upright and grasping the hand grips. A step or two should be taken into the walker, then it is lifted and placed in front of the patient again. Unfortunately, many orthopedic conditions will require prolonged periods of confinement to bed or at best, immobilization of the body part and restricted physical activity. This can lead to frustration and a feeling of hopelessness, as well as despair on the part of the patient. If the patient is a wage earner or a member of the family on whom others are dependent, there will be an additional burden of financial and role problems. Common musculoskeletal problems specific to musculoskeletal disorders are those related to immobility, pain, and self-care deficit. For shorter periods of immobility that occur with sprains and strains, joint injury and replacement, fractures, back pain, or arthritis, the goal is quick ambulation and rehabilitation with a return to an active lifestyle. The formation of contractures, which is shortening of skeletal muscle tissue causing a deformity, loss of muscle tone and fixation of joints can be prevented in most cases by a consistent nursing intervention. The major components of the intervention include gradual mobilization, an exercise program, proper positioning, and instruction of the patient and family. Within a matter of a few days, the structures of immobilized muscles and joints will begin to undergo changes. The pathologic changes most commonly associated with lack of mobilization or lack of motion include contractures, loss of muscle tone, and ankylosis, which is the permanent fixation of a joint. Joint motion is the result of a shortening and stretching of opposing muscles. When skeletal muscles are not regularly stretched and contracted to their normal limits, they attempt to adapt themselves to this limited use by becoming shorter and less elastic. An adaptive shortening or contracture will begin to form within 3 to 7 days after immobilization of a body part, and this process will be complete in about 6 to 8 weeks. This means that planning and implementing nursing measures should begin immediately to prevent permanent and crippling disability. The most common contractures that occur in patients immobilized for long periods of time include foot drop, knee and hip flexion contractures, wrist drop, and contractures of the fingers and arms. Muscle tone is defined as the readiness of the muscle to go to work, to contract and relax as needed. If a muscle is not regularly stimulated to action, or if it is stretched beyond its normal limits for an extended time, it will lose its ability to contract and relax. For example, in foot drop, the calf muscles are shortened while the opposing flexor muscles are stretched. The result is loss of muscle tone and inability to produce motion. Performing range of motion exercises can prevent this. Pain occurs with most musculoskeletal disorders. Analgesics, muscle relaxants, heat, cold, topical pain relieving substances, electrical stimulation, acupuncture, acupressure, massage, or chiropractic manipulation can be used to treat pain. Most hospital beds now have a built-in pressure relieving mattress to help prevent skin breakdown. Another type of bed for patients who are on bed rest for many hours each day has areas that inflate and deflate to deflect pressure from sequential areas of the body. Many critical care beds can be positioned into a chair shape, allowing the patient to sit up without ever having to move them out of bed. Wound care specialists are a good source for determining which type of bed would best help meet patient treatment goals. A sling used to support the wrist or elbow should support both joints of the arm. When a splint is applied to an extremity, it should support the joint that is to be immobilized, fit properly without impeding circulation or slipping out of place, and not cause any increased pain. A splint can be used on an extremity to limit the motion while healing takes place in the bone, joint, tendon, or muscle. Assess circulation after application of a splint. A brace or immobilizer can be used on a leg during healing of ankle injury or during the healing phase of a fracture. This device must be applied correctly, and the skin beneath it should be assessed for friction or injury every shift. Physical therapy sessions are often prescribed by the healthcare provider to assist the patient to regain mobility, increase strength after immobility, decrease pain, and prevent injury. In the acute setting, the physical therapist assesses functionality and rehabilitation potential. Recommendations will then be made to the provider. The occupational therapist assists the patient to perform ADLs using adaptive equipment or alternative movements. This will help the patient regain or maintain their independence. Observation of the patient's ability to accomplish ADLs will give clues to improvement in mobility and activity tolerance. Diagnostic test data from radiographs and lab reports can be used to determine the effectiveness of treatments.